Welcome to the deep dive. We're here to take the information you need, the stuff you need to learn, and make it much easier to grasp.
Exactly. You give us the sources, maybe revision notes like today, and we pull out the really crucial bits. It's like your personal knowledge shortcut.
Today, we've got a set of revision notes focusing entirely on renal cell cancer, RCC.
Really useful stuff, especially if you're, say, prepping for exams like the MSRA.
Right. So our mission for this deep dive is pretty clear. Transform these notes into a high-yield, easy-to-remember resource all about RCC.
Whether you're deep in study mode, just need a quick refresher, or, maybe you're just curious about it.
By the end of this, you should have a really solid handle on the key information. Okay, let's dive in. First off, what exactly is renal cell cancer?
Okay, so renal cell cancer, it's often called renal cell carcinoma too. It actually starts in the lining of these tiny tubes in the kidneys, the renal tubules.
The tubules.
Yeah.
They're the bits that filter blood and make urine, right?
Precisely. They're the workhorses. And here's a key thing from the notes. RCC makes up the vast majority, about 85% of primary kidney tumors in adults.
85%. Wow.
Yeah, it's a main player when we talk about kidney cancer in adults. Around 80% of all kidney neoplasms, actually.
So definitely significant. Are there different kinds?
Yes, absolutely. The notes list a few subtypes. The most common one is clear cell RCC. Then you've got papillary chromophobe and some, rarer types as well.
Clear cell, the most common. Got it.
And here's something really interesting and definitely high yield for recall. There's often a link to genetics, specifically structural changes on chromosome 3, the 3p arm.
3p, okay.
Yeah, particularly with the clear cell type. So maybe think 3p gives a clear view, something like that, to connect them.
That's helpful. And how does this RCC differ from, say, other things that can happen in the kidney, other tumors?
Good question. It's a crucial distinction. The notes point out that roughly 15% of kidney tumors are actually benign, so not cancerous.
Okay, like what?
Well, examples include transitional cell carcinoma, though, that actually starts in the lining of the urinary system, not the kidney tissue itself, which is important. Also, renal oncocytoma, Wilms' tumor, that's more childhood cancer, and angiomyolipoma.
So telling them apart is obviously step one for doctors.
Absolutely vital for getting the diagnosis and management right.
Okay, makes sense. We know what it is, where it starts. What about why it starts? What causes RCC? What are the risk factors?
Well, here's the thing. The notes state the precise cause isn't actually known, which is, kind of frustrating but important to know.
Oh, right. No single smoking gun.
Not really. But we do have several well-established risk factors, things that increase your chances. Smoking is a big one.
Okay.
Also obesity and having high blood pressure. A family history of kidney cancer definitely plays a role too.
And what about genetic links?
Yes, certain genetic conditions are strongly linked, especially von Hippel-Lindau syndrome. That's a key one to remember.
Von Hippel-Lindau. Tell me a bit more about that connection.
Sure. It's a hereditary condition. It causes various tumors and cysts to grow in different parts of the body. And the kidneys are definitely one of the affected areas. It creates a significant predisposition to RCC.
So a strong genetic component there?
Definitely. The notes also mentioned is generally more common in middle-aged men. And there's a slightly higher incidence in people with conditions like autosomal dominant polycystic kidney disease, chronic kidney disease,
right,
kidney transplant recipients, and those with acquired renal cystic disease.
Okay, quite a list. Is there a handy way to remember those key risk factors, like mnemonic?
Yeah, we could try one. How about SOH-Family-G for smoking, obesity, high blood pressure, family history, and genetic conditions like von Hippel-Lindau?
SOH-Family-G, I like it. Smoking, obesity, high blood pressure, family history, genetic. Okay, so a mix of lifestyle, genetics, other health issues. Now, how does it actually develop? The pathophysiology.
So going back to those renal tubule cells, RCC development involves genetic mutations, errors in the cell's instructions, basically.
Nice.
These mutations can mess with oncogenes. Think of those as the gas pedal for cell growth and also tumor suppressor genes, which are like the brakes.
Gas and brakes, got it.
Yeah. So if the oncogenes get stuck on anchors or the tumor suppressor genes fail, you get uncontrolled cell growth. And that's what leads to a tumor forming.
So it's fundamentally a problem with cell growth control. Okay, now, when a doctor suspects something's wrong with the kidney, what else are they thinking about besides RCC, the differential diagnosis?
Great point. The notes really stress considering those benign tumors we mentioned, especially oncocytoma. They can sometimes look quite similar on scans.
Okay, so benign mimics are important.
Definitely. And distinguishing RCC from other types of kidney cancer, like transitional cell carcinoma, is also critical. And of course, you always need to rule out completely different things causing, say, abdominal or flank pain, things unrelated to the kidney.
Makes sense. A broad perspective is needed initially.
Absolutely. You need a thorough workup to pinpoint the exact issue.
Let's zoom in on the UK situation for a moment. The epidemiology. How common is RCC here?
Well, the notes confirm it's the most common type of kidney cancer in the UK, again hitting that 85% mark we talked about.
Still the dominant type.
Yeah, and the chances of getting it definitely go up with age. Most cases are in people over 60. Overall, kidney cancer is the 7th most common cancer in the UK. About 4% of all new cancer diagnoses.
7th most common. And is there a peak age group?
There is. The highest incidence, according to these notes, is actually in the 85 to 89-year-old bracket. And a pretty large chunk, about 34%, over a third of diagnoses happen in people 75 or older.
So significantly skewed towards older adults.
Very much so. The notes also mention, interestingly, that rates can vary a bit depending on socioeconomic status, ethnicity, and gender within the UK.
And the hereditary link, how common is that in the UK?
It's estimated around 2 to 3% of RCC cases are hereditary, often tied back to that von Hippel-Lindau disease we discussed.
Okay, 2-3%. And what's the trend? Is it becoming more common here?
This is quite concerning, actually. The notes indicate a steady increase. Between 1993 and 2014, the incidence rose by about 3.1% per year.
Wow, annually.
Annually. And the projections aren't great either. They suggest a further 15% rise in kidney cancer incidence between 2023-2025, and then again between 2038-2040.
That's a worryingly clear trend. Okay, so bearing that in mind, how does RCC actually show up? What are the clinical signs, the symptoms someone might notice?
So the common things listed are hematuria, that's blood in the urine, a really key sign.
Right, visible or non-visible?
Can be either, but unexplained visible blood is a major flag. Then there's flank pain, often described as a dull, persistent ache in the side or back, and sometimes a palpable mass, something the doctor can actually feel in the abdomen.
Okay. Blood, pain, mass. That sounds like the classic triad I've heard about.
Exactly, that's the one. Hematuria, loin pain, which is basically flank pain, and an abdominal mass. We could use HALT, hematuria, abdominal mass, loin pain, HALP, hematuria, abdominal mass, loin pain, HALP maybe.
HALP. Okay, helps remember it, but you don't always get all three.
No, definitely not. That's really important, especially early on. Other things might include just feeling really tired, fatigue, unexplained weight loss.
More general symptoms?
Yeah, or even a fever with no obvious cause. A pyrexia of unknown origin. And sometimes there are endocrine effects, like the tumor making too much erythropoietin, leading to polycythemia, too many red blood cells.
Polycythemia?
Oh.
Okay. That's quite a spectrum. Are there other ways it can present?
Yes, and this is quite sobering. The notes say about 25%, a quarter of patients, already have metastases when they're first diagnosed. The cancer is already spread.
So a quarter. Wow. Okay.
Yeah. There's also something called perineoplastic hepatic dysfunction syndrome affects the liver, and a varicocele, which is swollen veins in the scrotum, usually on the left side, sometimes linked to Stauffer syndrome.
Left-sided varicocele. Interesting.
But here's another key takeaway. RCC is often asymptomatic initially. The notes suggest maybe 50% of cases don't have symptoms at first.
Half the cases have no symptoms. That's huge. That really underlines the challenge for early detection, doesn't it?
It really does. Makes screening difficult and highlights why picking up on subtle signs or investigating incidental findings on scans is so important.
What about signs of more advanced disease?
Well, the notes mention that a varicocele that doesn't go down when lying flat, especially if it's on the right side or swelling in both legs, might suggest that cancer is more advanced, perhaps involving the vena cava.
Okay.
And around 30% of patients might present mainly with those perineoplastic symptoms we mentioned, like the high red cell count or high calcium.
And if it has spread, metastasized.
Then you might see symptoms related to where it's gone. A persistent cough if it's in the lungs, swollen glands or nodes, bone pain. The most common sites for spread are the lungs and bones. It tends to cause osteolytic lesions in the bone, meaning it destroys bone tissue.
Lungs and bone. Okay. And can it spread locally too?
Yes, it can grow into structures right next to the kidney or even into the major veins like the renal vein or the vena cava.
Okay, this is a lot to take in clinically. The notes also mention staging, specifically the T category, to describe the tumor itself. Can you break that down simply?
Sure. Think of T as describing the tumor size and how far it's grown locally. T1 is the smallest category, 7 centimeters or less. and it's just within the kidney.
T1, small, contained.
Exactly. T2 is bigger, more than 7 centimeters, but still totally confined to the kidney.
T2, bigger, but still contained.
Right. T3 is where it starts to extend. It might grow into the major veins or into the fatty tissue just around the kidney, but not into the adrenal gland on the same side and not beyond a fibrous layer called Gerota's fascia.
T3, growing out a bit into fat or veins.
Correct. And finally, T4 is when it's really broken out. It's gone beyond Gerota's fascia, maybe invading the adrenal gland directly.
T4 invaded beyond the kidney's immediate surroundings. Okay, that helps classify the primary tumor. So if someone comes in with suspicious symptoms or maybe an incidental finding, what investigations happen?
Imaging is absolutely central.
Yes.
A CT scan is usually the key investigation. It helps diagnose the RCC and, crucially, assess how far it might have spread, looking for that T stage and any spread elsewhere in the abdomen.
CT first, usually. What about others?
MRI and ultrasound can be useful too, maybe for clarifying certain things or in specific situations, like if contrast dye for CT is an issue. And if there's any worry about chest spread, then a chest CT is needed for staging.
But imaging alone isn't the final answer.
Not usually for a definitive diagnosis, no. A biopsy is typically needed. A small sample of the suspicious tissue is taken and looked at under a microscope by a pathologist that confirms if it is cancer and what type.
Biopsy for confirmation.
Okay. Are there fast-track referrals for this?
Yes, very important. The notes mention the suspected cancer pathway referral, aiming for an appointment within 2 weeks. This is usually triggered for people aged 75 or over who have unexplained visible blood in their urine.
Right.
If they have blood in their urine, maybe non-visible, that persists after treatment for a UTI.
So specific criteria for urgent referral. Definitely. And in some cases, particularly if there's a strong family history or signs suggesting something like von Hippel-Lindau, genetic assessment might be considered.
Okay. And once you have the diagnosis and the imaging, you mentioned staging. How does the full T&M system work?
Right. T&M gives the full picture. T is for the primary tumor, like we just discussed. N is for nodes, has it spread to nearby lymph nodes. And M is for metastasis, has it spread to distant parts of the body.
T-N, M tumor, nodes, metastasis.
Exactly. The notes mention the 2017 version. These are then combined into overall stage groups from stage Y to stage Phi, which gives a clearer idea of prognosis and guides treatment.
Can you quickly outline those stages?
Sure. Stage I is basically T1, no nodes involved, N0, no distant spread, M0, small, contained.
Stage I, small, localized.
Stage 2 is T2, N0, M0, so a larger tumor, but still confined to the kidney, no spread.
Stage 2, larger but localized.
Stage 3 gets a bit more complex. It could be a T3 tumor with no node or distant spread, T3, N0, M0. Or it could be any T1, T2, or T3 tumor that has spread to nearby lymph nodes, N1, but still no distant metastasis, M0.
Stage 3, locally advanced or node involvement.
Correct. And stage 4 is the most advanced. This includes any tumor that's grown really far locally, T4, regardless of node status, but with no distant spread, T4, NE, N0. Or it means there is distant metastasis, NET, NEN, M1.
Stage 4, very locally advanced or distant spread. Got it. That staging is obviously critical for deciding what to do next. So let's talk management. How is RCC treated?
Yeah, it's crucial. And management really hinges on that stage, plus the patient's overall health. It's very individualized. The main approaches involve surgery, targeted therapy, immunotherapy, and sometimes radiation therapy.
Okay. What about for early stage confined disease, stages I and II?
For those, surgery is the cornerstone. The aim is usually curative. It might be a partial nephrectomy, removing just the tumor and a bit of surrounding kidney tissue, or radical nephrectomy, removing the whole kidney.
Partial versus radical. What decides that?
Often the size and location of the tumor. If possible, a partial nephrectomy is preferred, especially for smaller tumors, because it saves kidney function, which is really important long-term. Nephron sparing, they call it.
Makes sense. Preserve function if you can.
Exactly. The notes also mention that minimally invasive approaches like robot-assisted or laparoscopic partial nephrectomy often lead to better recovery and are recommended by NICE where appropriate.
Okay. Any mention of older systemic treatments?
Yes. Historically, things like alpha interferon and interleukin-2 were used, particularly for metastatic disease, trying to stimulate the immune system. But the notes highlight that newer targeted therapies receptor tyrosine kinase inhibitors like sunitinib and sorafenib and modern immunotherapies have generally proven more effective, especially for metastatic disease.
So for localized disease, surgery is key, preferably partial nephrectomy. What about lymph nodes or tumor thrombus at this stage?
Lymph node removal, or lymphadenectomy, might be done for staging purposes if nodes look suspicious on scans, but its routine removal isn't always necessary if they look clear. If there's tumor thrombus, so cancer growing into the veins, but no distant spread, removing that thrombus completely during the nephrectomy significantly improves the prognosis.
Okay. Are there non-surgical options for localized RCC?
Yes, for certain patients, maybe someone who isn't fit for major surgery or has a very small, slow-growing tumor. Options include active surveillance or watchful waiting, just monitoring it closely,
Right.
or ablative techniques like cryoablation using cold to freeze the tumor, or radiofrequency ablation using heat.
Right.
These are less invasive than surgery but might carry a slightly higher risk of the cancer coming back later.
So alternatives exist, but maybe with trade-offs. What about locally advanced disease, stage 3?
Here, surgery is still often the main approach, if possible, aiming to remove the kidney and any local spread. If lymph nodes are clearly involved, clinically positive, then lymph node dissection is usually done. And again, if there's tumor thrombus without distant mets, removing it is key.
Any role for treatments after surgery in this setting? Adjuvant therapy?
Generally, the notes suggest limited benefit from things like chemotherapy or radiation given routinely after surgery for locally advanced disease to prevent recurrence, although research is ongoing. If the tumor is unresectable, sometimes embolization blocking its blood supply can be used to control symptoms like bleeding.
Okay. And then for the most advanced stage, stage 4, metastatic disease.
This is where systemic therapies really come into play. Even with spread, if the patient is fit enough, removing the primary kidney tumor, a cytoreductive nephrectomy, might still be beneficial in some cases, often before starting systemic treatment.
And those systemic treatments.
Targeted therapies like sunitinib, pazopanib, everolimus are mainstays. And immunotherapies would get really important drugs like nivolumab, often combined with ipilimumab, or older ones like IFN-alpha or IL-2 for certain clear cell cases. The choice depends on various factors, including risk category and previous treatments.
Targeted therapy and immunotherapy, key players now.
Absolutely. Local treatments might also be used for specific metastatic sites like surgery to remove an isolated metastasectomy, or radiation therapy for symptom control, perhaps for bone pain.
And for bone mets specifically.
Yes, bisphosphonates like zoledronic acid are often used to help strengthen bones and reduce the risk of fractures or other skeletal problems.
It's clear the treatment is complex and multifaceted, especially for advanced disease. What about the outlook, the prognosis?
As you'd expect, it really depends heavily on the stage of diagnosis. Early stage, confined cancers have a much better prognosis. Advanced metastatic cancers have a poorer outlook and need those more aggressive, often ongoing treatments.
Can you give some figures UK survival rates?
Yeah, the notes provide data for England from 2013-2017. 1-year survival was around 79%, 5-year survival about 64%, and 10-year survival roughly 52%.
So just over half surviving 10 years overall.
Overall, yes, but it's improving. The notes point out that survival rates in the UK have got better over the last 40 years.
That's encouraging.
It is, and survival is much better for younger patients and, crucially, for those diagnosed early. Stage II diagnosis, for instance, has a 1-year survival around 96% and 5-year survival around 87%. Huge difference.
Massive difference. Early diagnosis is everything.
Pretty much. Though the notes do mention that UK kidney cancer survival, while improving, still lags a bit behind the European average. So continuing efforts in prevention, early detection, and treatment are vital.
Which brings us back to prevention smoking, obesity, awareness of family history.
Exactly. Addressing those modifiable risk factors is key.
Okay. Lastly, what about complications, either from the RCC itself or the treatment?
The biggest complication of RCC itself is metastasis, as we've covered. Lungs, bones, liver being common sites. There's also the risk of recurrence, the cancer coming back after treatment, even after successful surgery. And treatments themselves can have side effects and complications, of course, depending on the specific therapy.
And those perineoplastic syndromes.
Yes, there are important complications too. Polycythemia from excess erythropoietin production by the tumor, and hypercalcemia, high calcium levels, due to the tumor making a parathyroid hormone-like substance. These need managing alongside the cancer itself.
Polycythemia and hypercalcemia. Got it. Phew. Okay, that was a really comprehensive run-through based on these notes. Hugely helpful, especially for revision. Any final quick memory aids or maybe another example question?
Sure. Remember HALP for the classic triad, hematuria, abdominal mass, loin pain, and SOH-Family-G for risk factors, smoking, obesity, high blood pressure, family history, genetic. For staging, maybe just T1, T2 cues a kidney only. T3, T4 equals beyond kidney. Pretty simplified, but a start.
Simple is good for recall.
And an example question. A 60-year-old patient is diagnosed with clear cell RCC. Which chromosomal abnormality is most commonly associated with this subtype?
Okay. Based on what you said, that would be chromosome 3p deletion or
Okay,
changes, right?
exactly. See, you've got it. Thinking about those key associations is really useful for exams like the MSRA.
Brilliant. So, quick summary. RCC starts in kidney tubules, clear cell is most common, linked to 3p. Risk factors include smoking, obesity, hypertension, family history, von Hippel-Lindau. Can present with HLP triad, but often asymptomatic or has nonspecific signs. Diagnosis via imaging, CT, and biopsy. Staging, TNM, guides treatment. Surgery for localized systemic therapy, targeted immuno for advanced. Prognosis depends heavily on stage.
That's a great wrap-up. Covers the high points perfectly.
Excellent. This deep dive format really helps solidify things. Thanks so much for walking us through all that detail.
My pleasure. Hopefully useful for anyone listening.
Absolutely. And remember, if you need to review any part of this, just skip back. Now, here's something to maybe think about further. Given that RCC incidence is rising and early detection is so crucial but challenging due to asymptomatic presentation, where should research efforts be most focused? Better screening, understanding the causes more deeply, or developing even smarter, kinder treatments?
That's the million-dollar question, isn't it? A lot to consider there.
Definitely food for thought. And if you are studying for the MSRA or just want more high-quality medical revision resources, seriously, go check out passthemsra.com and their sister site, freemsra.com. Invaluable stuff.
Really good resources.
Well, that's all for this deep dive. Thanks for joining us.